thank each of you for making it and joining us for our 10th episode of season 5. We do have a little something that we would like to share prior to the show, if that's okay. There's something that is entitled Miriam, a Gift of Light. In the heart of America, a gentle soul resides. Miriam Tennant, where love and kindness abide. A caring heart, a spirit ever bright, a beacon shining, filled with heaven's light. Dr. Tennant's beautiful bride, a partner true and dear. Her healing touch, her encouragement and hope, dispelling every fear. With loving and open arms, she welcomes one and all, a gift of light to this world, answering every call. Her love is a healing balm that soothes the weary soul, making lives worthwhile and making spirits whole. Through many trials faced, her strength and grace endure, a testament to heaven's love, true and forever pure. On this, your day, we celebrate your birth, a soul so precious of immeasurable worth. May love, joy, and peace forever fill your days, our dearest Miriam, in countlessly loving ways. Life is filled with miracles. In your reflection, we hope you see you are one of the best miracles that will ever be.
Wow.
Happy birthday.
Happy birthday.
Thank you.
Happy birthday,
Miriam.
Happy birthday, Miriam.
Happy birthday, Miriam.
That's
Thank you
beautiful.
so much.
That's
One and
beautiful.
all. One and all. Thank you. That was
Happy
beautiful.
birthday, Miriam.
Beautiful.
Birthday, Mrs. Tennant.
Thank you. Thank
Happy
you.
birthday.
Thank you. Thank you. Love
And
you
we
all.
love you so much.
Love you. Yes.
Thank God we
You made
didn't
my day.
sing.
Oh, if you insist.
No. After what we did to Dr. Tennant, I don't think we should.
We're so thankful. Thank you all for doing that with us. That was sweet. And I'm sure she enjoyed that. And Miriam, I hope you did. I hope that brought a smile to your heart. And we'll go ahead and get started. Dr. Tennant, I know you have a lot planned for us today. And so we have a lot going on. So we'll just go ahead and turn it over to you. Thank you so much.
Well, thank you. And I'll have to admit your birthday recognition of Miriam is a surprise to me and a most pleasant one. I wouldn't be here if it wasn't for her. She and I decided some years ago that we would take our efforts and what have you in our later years and dedicate it to the cause of pain patients and suffering people who just have been cast out. So she's with me all the way on this, and we do it together. I might also mention that I have some lovely people who are not only in our foundation's office, but outside who do research for me. And at some point, you'll get a chance to meet some of them. So anyway, thank you very much for Miriam. It's a surprise to us. And again, all we can say is we've our desire to take on this cause has been rewarded back to us many times over, and you're a great part of it. And you're a great family, a great community, as I like to call it. To go ahead and get started with the official part of the program, we're going to use our same format. We've got a little education here at the front. Dr. Ibsen and Dr. Guest both have, I've given them assignments this week to answer some questions that may not have answers, but they have opinions. So we're going to discuss that. We've got a great guest coming on later today. So let me get started. I think I promised everybody that from our perspective, the reality that the Epstein-Barr virus is intimately connected to severe chronic pain conditions has to be addressed continuously, because it is somewhat new and complex, but also quite dangerous. In fact, that's one of our problems. People don't realize how serious the situation is. When we talk about the Epstein-Barr virus, I want to make it clear that we're talking about people who have a constant chronic severe pain condition. We're not talking about people with mononucleosis at college. We're not talking about somebody who may think they've got chronic fatigue syndrome due to it or something like that. We're addressing one of the two major problems with this virus. Now, this virus medically has two problems. Number one, it causes certain kinds of cancers. And number two, it causes painful conditions, of which some of those are recognized now as autoimmune conditions. And they should all be recognized probably as autoimmune conditions. Now, people, we're getting daily into our foundation, I mean daily, reports, laboratory reports on the Epstein-Barr virus testing, and we're able to compare that with their clinical picture. So we're probably got a base of better data right now than anybody in the world, and we're going to pass some of this on as we learn about it. We've still got a lot of questions, but nevertheless, we've got some pretty good grounding here. Some of you are familiar with the study that we just finished, in which it was entitled Stopping the Deterioration of Adhesive Arachnoiditis. A couple of things came out of that study. One is that everybody who had adhesive arachnoiditis, out of 45 people, only one or two did not have painful conditions other than arachnoiditis that occurred prior to developing that condition. And now we're tracking it. When the Epstein-Barr virus decides to reactivate, the first disease it may give you is migraine headaches. It may be a herniated disc. It may be fibromyalgia. It may be a carpal tunnel syndrome. It may be small fiber neuropathy or sciatica. In other words, we now understand how the virus works, and that it looks like it can cause a number of painful conditions. Okay. And in fact, who should be tested for the Epstein-Barr with a panel? Anybody, in my opinion, who's got severe chronic pain that just doesn't go away. And chronic pain is usually defined classically as anything that lasts over 90 days. So if a person has severe pain lasting over 90 days, you cannot go wrong by getting the Epstein-Barr panel blood test. Now, the panel blood test, normally if you ask Quest or LabCorp, you ask your local hospital, you go to Life Extension, they're going to run 3 or maybe 4 of the 6 tests that are available, okay? Now, one of the difficulties is that practicing physicians at this time, I doubt if there's more than a handful anywhere yet that would know what all 6 of the tests mean, okay? So we're all learning. Now, of the 6 tests, we're going to eliminate one out front. One of the 6 tests is specifically for cancer of the nose or throat, okay? So there's actually a test for that caused by the Epstein-Barr virus. We actually have a test like that now. And it's not well known, but certainly it's one that I look at and advocate for every once in a while. It's strictly for the cancer. We have a second test, and this is really confusing to the doctors. We have it, and it's called a viral capsid antigen antibody, abbreviated VCA, and it's what they call an IgM antibody. That means it's early on. The M wasn't meant to be, but you can kind of relate it to meaning infectious mononucleosis, okay? Now, infectious mononucleosis is all in 99% times out of 100 is acute, occurs in the teenage years or young adult years, known as a kissing disease. You get over it, the virus goes into its parasitic state, and you're asymptomatic after that. However, a handful do not go away and develops a condition known as chronic mononucleosis. Now, in chronic pain patients, including adhesive arachnoiditis, we're finding that about 5% have what is known as chronic mononucleosis. Okay, serious condition. You don't live very long with that unless you get it recognized and treated vigorously. It's unusual, but it does exist, and we're now seeing it show up in the test results of people with severe chronic pain. Now, there are 4 other tests, okay? 4 other tests. And some of you are going to want to learn these. If not, you can look it up. We're trying to get out information. One of the tests tells you whether you've had recurrent reactivations, okay? Okay? And the lab test will come back and say you had it in the past. That's all it'll say. But if the test is real high, you can be assured it's due to multiple reactivations over time. And the second test is what's known as the nuclear antigen test. And if that gets real high, that means you've got some autoantibodies and probably autoimmunity, and that's also got to be treated. Now, 2 of the tests are to determine if the virus is active today, on the day the test was taken. Okay. Now, what we're finding out in the testing we're doing is that about half have active virus and about half do not. Okay. Half do not. And that's why the studies showing that antiviral drugs didn't do much good is they were giving them to people that didn't have active virus. But if you've got active Epstein-Barr virus, you need antiviral treatment. Now, that may sound a little complex, and it is. It's taken me a while to figure it all out, get it straightened out on a clinical basis, because, again, anything to do with chronic severe pain, nobody's doing much research. Nobody seems to care much, except those of you who are involved with our community here. At any rate, what I want everybody to know is that you've got 6 tests. And people who, like myself, who are going to sort of specialize in this disease are going to know what those tests mean. However, most people are only going to be using about 4 of the tests. Now here's what they're for. 1 is for reactivation. 1 is to determine if you've got autoimmunity. And the other one is determine if you've got live virus floating around your system, infiltrating your cauda equina, your small nerves, your muscles, your meninges. That's infiltration. Okay. Now, what I want to talk about tonight and is what I call the cornerstone of Epstein-Barr control. Okay. And we're going to use the term control here, unfortunately, because the autoimmunity that's created by these viruses probably doesn't ever go away. It's indefinite. It's the same autoimmunity that you have with rheumatoid arthritis, scleroderma, lupus, Sjogren's, and other autoimmune diseases. The autoimmunity may not be curable. It may go on for a long time and maybe a lifetime. Now, the situation is this. You have to, in the testing, clinically, you've got to treat the reactivation, try to prevent it. You're going to have to suppress the autoimmunity. And if you've got infiltration of the virus, you've got to try to wipe out the virus. Now, what I want to talk about now is the reactivation. If a person can stop the reactivation, then you've really got a shot at calming the system down. And we're getting a lot of reports back now that when people have a good reactivation program, their pain gets better, their function gets better, their overall situation does get better. I'm surprised. And sometimes they come back and say, yeah, I'm better after a week or 10 days. I'm a little surprised. But if you can prevent the virus from reactivating, the virus that's infiltrated will die off because it's a living thing. It only has a lifespan, just like the flu or COVID. It does disappear after a while if you can keep from reactivating again. Okay? Autoimmunity is different. You're going to have to treat that. But on the reactivation, what I wanted to tell you is that there have now been about 3 laboratory studies in which researchers have determined a list of agents that prevent reactivation. Okay? They prevent these. And I'm going to be sending out a bulletin on this next week because I want everybody that's got chronic pain, particularly if you've got some of the severe things like RSD, AA, small fiber neuropathy, pudendal neuropathy. If you've got one of the really serious problems, you're going to want to take a look at the list of agents, medicinals that prevent reactivation, and get that to your nurse practitioner, get that to your physician, get to that to your chiropractor, and so they can know that these things have been studied in controlled laboratories. Now, I'm going to read to you the agents that are known to, in the laboratory, prevent reactivation. And a lot of them you know. Vitamin C, vitamin D, resveratrol, luteolin, astragalus, curcumin, andrographis, cimetidine, selenium, zinc, and lysine. Those are the ones that have been shown, at least in the laboratory, to suppress the Epstein-Barr virus, the reactivation. Now, I'm going to give you the Dr. Tennant program, okay? I'm going to give you what I'm now recommending. When that laboratory test comes back and you've got elevations of both your reactivation test and your autoimmune test, and it's at least 2 times normal and you've got chronic severe pain, here is my recommendation, okay? Now, there may be a better program out there. I'm still working on it, but here's the one I've got today. Number 1, vitamin C, 2,000 to 4,000 milligrams a day. You can buy a whole jar down at Vitamin Shop or somewhere of vitamin C, 2,000 to 4,000 milligrams a day. The mineral I like best is selenium. Now, some doctors might like zinc better, but I like selenium, 100 to 200 milligrams a day. Now, let me give you the 2 that our studies are showing are really getting to be patient favorites, doctor favorites. One is something called monolaurin, okay, monolauren. That is a derivative of coconut oil. Does not require a prescription. There's about 3 dosages, and I'd get the highest dose. So monolaurin is becoming very popular. Now, the 4th one is the new kid on the block, but the one I like best, and that is thymosin. Thymosin. Now, thymosin has been recently made, and it is both an immune suppressing agent made in the thymus gland, but it's also a polypeptide. So you get 2 things. In some circles, it's called the hormonal peptide, okay? But thymosin, monolaurin, vitamin C, and selenium, that's the Dr. Tennant recommendations this time. You may come up with a better one down the line, but those are the 2 things that, again, if you've got severe chronic pain and that Epstein-Barr virus test comes back with elevated VCA and EBNA antibodies, that's my recommendation. Okay.
Can I interrupt for just a second?
Sure.
From the pharmacist standpoint, if you guys are going to start on 2,000 to 4,000 milligrams of vitamin C a day, make sure you drink lots of water to get that stuff flushed through the kidneys so you don't end up with a vitamin C kidney stones.
Good point. Great point. Any other thoughts on that at all? You have a favorite at all of that list?
Well, the 2 of them are totally completely new to me, but I've always liked vitamin C. I just want to make sure it gets doesn't get clogged up in those kidneys.
I corresponded with Dr. Pauling when he was alive, and I really like Emergency because it's a multi-mineral ascorbate, and it doesn't cause the problems that like sodium ascorbate or ascorbic acid cause. It's a little expensive, but you also get all of the like electrolytes in it. So I really like Emergency.
Yeah. Yeah. Oh, good point. Incidentally, there are a lot of commercial preparations combining a lot of these things coming out. I don't know a bad one out there. They may be a lot better than what I'm recommending. The key is do something. Okay, get something that's on that list to try to prevent the reactivation, and we'll hear more about that as time goes on. I'll just say one thing, and then I want to get on with the program. Unfortunately, you can suppress the reactivation, you can kill off the virus, but left behind is the autoimmunity. That is a separate process. Okay? Incidentally, I read a nice simple definition of autoimmunity this week. It's when some element in the body mistakenly identifies your tissue and attacks it. Okay? It's a mistake by something in the body. At any rate, you treat that with, that's where the corticoids and the ketorolac come in. We'll cover that in another session. I want to switch now to Dr. Guess and Dr. Ibsen, if I might. I sent them some questions this week. And before they dodge the questions, if they can, I want to bring to everybody's attention something that's happened in this country that's not well appreciated. And that is between the years 1985 and 2005, a number of university medical centers in this country, probably in half the states, opened up pain units. And we could send a difficult case there, somebody that needed 2,000 milligrams of morphine equivalent, somebody that had 3 or 4 different painful conditions, somebody who was just too much for the general practitioner to handle. For your information, the traditional job of universities in this country, at least the medical centers, have been to take the difficult cases because, first of all, that's how students learned. But beginning in those years, they closed their pain programs. I remember very well in California, UC Davis, that's in Sacramento, closed their pain program. And I got an SOS to go up and help some nurse practitioners up in Grass Valley and up in Northern California take all their patients and try to set up a clinic for them. They just shut it down overnight. And this happened all over the country. Now today, of all the 50 states, I can't identify a single university medical center who will take your difficult medical case. Oh, one of them might put a stump implant in you for morphine or put a stimulator in you. But I'm talking about taking over the difficult case to manage the opioids, manage the other drugs, and to help the general practitioner manage the case. Now, my question that I wrote to Dr. Ibsen and Dr. Guess is what happened? Why did the universities bail out? And what's worse, I can't find a single university medical center in this country who now backs the use of opioids. They were university people who wrote the CDC guidelines. In other words, the universities have not only bailed on us, they are fighting us. Now, my question to Scott and Mark, give me your opinion on this movement. It's not well appreciated by the public, but I think the practicing physicians asking, where are the universities like they used to be?
They drank the Kool-Aid. They bought the CDC guidelines. They'll help you manage your case now. But what they'll do is they'll help you manage that patient down to 90 morphine milliequivalents or less. The patients that I used to have that are still going to university centers, they're trying to get them completely off of their opioids. And let's see, the second question, I didn't have an answer for. The third question, I still use the WHO ladder. I think it's a very simplistic 3-step way to manage pain.
Yeah. Mark, are you there?
I am.
Good. Can you weigh in on this? Scott jumped in on my one of my other questions, but
I'm sorry.
Oh, that's
We're doing it
okay.
one at a time.
Yeah.
it's the
He-
same.
he's a genius. It's okay. He's ahead of us all the time.
There
Yeah.
you go. That's
Um,
true.
so I think what happened is um, university systems used to get grants, and they used to be um, what is that, public good, that they would be able to service the public good, and therefore had an obligation to treat the underserved and to treat complex, mysterious cases. I believe that the university systems are now economic engines, and they cannot afford to be taken offline or have any of their doctors taken offline by getting into some trouble by losing their license or losing their certificate of registration with the DEA. My experience at the Cleveland Clinic fits that. I mean, they're a very multidisciplinary organization. They're, um, uh, it's a melting pot from people all over the world with lots of brilliant people working there. There's no reason that they didn't tumble onto everything that the rest of us have tumbled onto. So I think it's excuse me, get another call. I think it's more than just cowardice. It's economic survival. I mean, I don't think they can survive if the DEA shuts them down or they get labeled a university pill mill or something. I think the stigma around opiates, addiction, pill mills, bad doctors, overprescribing, all that stuff has had them pull the reins in and say we're not touching that because we can't win. And I got news for you: we're going to start winning.
Yeah, that's a good analogy. Then who was supposed to win?
Well, yeah, I mean, it used to be the patient was number one, but that's, of course, not the case anymore. So the major universities are just basically afraid of losing their economic momentum. They're afraid of having to close down, and they're no longer funded as a community good. They have to generate income on their own, there isn't there is no charity medical care in America. So you can't operate on charity. Training programs have been whittled down, and this is probably good. You can't really abuse residents as much as they used to. When I was a resident, the complaint was, well, the problem with being on every other night call is you miss 50% of the pathology. So they used to just want us on call all the time, and it was free labor for them, and that's not doable anymore. And I think that has a factor there. But I'm either now or later I can talk about the Neil Anand trial that I'm at in Philadelphia. You want me to do that now, Jamie?
I would, Mark. Let me just let's go back to that trial.
Okay.
Scott just started for a moment. I would like for everybody that's here. I'm sure that we as professionals are the only ones who know there is something or was something called the World Health Organization 3-step ladder for opioid treatment. And this was the standard. It was developed in 1980, 82. And this was the rule of the day right up until around the time that the crackdown came. And let's see, Scott, you still
Yes,
there?
sir. I'm still here.
Could you give them an explanation about what the World Health Organization ladder said?
It was 3 steps. Your first step is what basic first aid. You're going to use braces, hot and cold, non-steroidal anti-inflammatories, and acetaminophen. The next step was weak opioids like tramadol, when it was around, Darvocet. We don't have that anymore. Tylenol with codeine. Codeine is a weaker opioid than, say, morphine. And then the third step was up to your stronger opioids. just three real steps, and it's basically very straightforward, very logical.
Yeah. And then what
And I
happened to
still
it?
use it.
Well, it's just plain old simple common sense medicine.
Yeah, it's
So,
still very valid.
So, but how many people have even heard of it?
They're not teaching it anymore at the national conferences, at least not the last two that I've been to.
Mm-hmm. Yeah.
Well, I can tell you from the it's not the horse's mouth. I would think it would be a donkey's mouth, from Dr. Timothy King, who I spent the last 2 days with, watching him testify and try and ruin the life of Dr. Anand. He said two stunning things. One is there's no safe dose of opiates, which just stunned me to
Oh,
hear him say that. That's a quote from the CDC, apparently. And he disavowed the World Health Organization step program. So it was just nauseating to see. But
well, apparently we've also withdrawn from the World Health Organization as a nation.
it's true. Yeah, there's that.
Well, do you want to segue right into tell us about the trial? What's the
Yes. So Dr. Neil Anand is an interventional pain physician, and he and I have become close friends. Before this thing started, Ira was talking about how great relationships can happen over the internet and not ever be in person. Well, I met Dr. Anand for the first time, and he and I are like brothers for the last 7 years since he was taken out in a raid in 2018, I believe. Um, and so in this trial, they're claiming that he's guilty of Medicare fraud and overprescribing of narcotics and opiates. And the first day of the trial was a lot of confrontation and a grumpy judge. And, I wore my white coat and they told me not to come back with my white coat on. Just a lot of like control issues in the courtroom. The second day was Dr. Timothy King testifying about basically they had an undercover agent, an undercover informant recording Dr. Anand's office. And Dr. Anand is not in any of these videos. And it's about 2 hours worth of video, and they showed about 5 minutes of it where the patient was given um, uh, the non-opiate prescriptions in a bag before they met the doctor who would write the opioid prescription. So they'd be given some topical creams like diclofenac or Voltaren. They'd be given their muscle relaxers and maybe sleeping pills, that sort of thing. The testimony of Dr. King called it a goodie bag. I kid you not, he called it a goodie bag, like they were. Uh, it sounds like when I go to the dentist, I get a little tube of toothpaste and a new toothbrush every time. And it seems kind of like that. But he was critical of Dr. Anand's practice because he felt like these were indiscriminate use of all these other alternative medicines in addition to using an opiate. So so what I saw here is that if you use only opiates, you're guilty of running a pill mill. And if, like Dr. Anand, you use other things besides opiates, you're guilty of using a goodie bag. In other words, nobody wins in that circumstance. Now the good news is later on this afternoon, Dr. King kind of fell on his face, and the prosecution had a big meltdown, and the trial might even be over because he really didn't make his point with the jury, particularly after they played the entire length of the video that was shot by the undercover agent. And essentially, it's entrapment, it's targeting. And we haven't even gotten into the false data mining stuff, and use of NARCS care scores and all that stuff, which is secretly proprietary, which no one can find out how they came up with these systems, and they're also false in how they limit how many. They've been used to convict lots of doctors, and now the tide is turning. Dr. Rafai was there today. He was acquitted. Dr. Russo was there today. He was acquitted in Michigan. Dr. Pompey was acquitted in Michigan. So we're having a lot, a concentration of cases that are being acquitted now instead of automatically railroading the doctors. So I'm excited today from what I'm seeing at this trial.
Now, who is this Dr. Kane? I've been in this field a long, long time. I've never heard of the gentleman. Can you tell us who he is?
Well, I would, the only argument I would use in that question would be the term gentleman, but
It's a
I
habit
have
with me calling
I have
everybody
some,
to do what they do.
PG rated things to say about him. But he's an anesthesiologist from upstate New York. He did an anesthesiology residency. He's proud of his 50 years of service to the medical system. And so I'm not gonna berate anybody for 50 years of service. I'm getting close. You're way beyond that, Dr. Tennant. And so he found, I think 15 years ago, he started testifying in cases about 2014, 2013. And basically what he said is that you got to have a full examination of every patient. You can't, and that Dr. Anand's practice was not practicing medicine at all. He said, this isn't really medicine. If you give a bunch of stuff in a bag to somebody, that's not appropriate medicine. It has to be individualized, and including pain creams, Aspirin cream, for God's sake. You could buy that over the counter. So I think he is been able to make about $400,000 or $500,000 a year testifying against doctors and getting paid by the government. And so he's found his little gold mine and he's been mining it. But I think he's going to go bust here. I think the end of his gold mine is coming. And I'm glad you haven't heard from him because he's a scumbag.
Well, I can say, all I can say is that I was an editor for a dozen years, and as you know, I've been around forever, and all of a sudden somebody shows up as this world-class, know-it-all consultant. Where did they come from?
Yeah.
Where did they get these people? Yeah, well, that's amazing. But I'd like to thank you. Next week,
Thank you.
let's get an update on this. This is
I will.
exciting, and I hope that it sounds very encouraging. Next, Jamie, if you'll bring our guest on.
Yes, sir. We have Miss Danita with us. Welcome, Danita, to Doc Talks. Thank you for being with us.
Thank you. And thank Dr. Dr. Tennant, Dr. Ibsen, everybody, Jamie, this whole family. Thank you all.
Yep. Danita, well, thanks for coming on. I know you've had an interesting life and an interesting story. Some you'd like to forget and get rid of, I know. But at any rate, could we, let's start at the beginning. Where do you live?
I live in Northwest Arkansas.
You're in Northwest Arkansas. And you've been, tell us, at this time, as I understand it, you are an EDS patient.
Yes, I was diagnosed 4 years ago.
4 years ago.
I'm 66. I don't know.
They waited a while. Yeah.
I think they may have suspected it because all my life I had limitations. I wasn't allowed to take PE, braces. I was under the care of a very good ortho surgeon. I don't know if they suspected it and just didn't put the label on it. I'm not sure.
Let me go back. What do you recall, or when do you recall as either a child or a teenager having your first health problem, first pain problem? Can you go right back to the very first thing you noticed?
Well, what they called growing pains was really bad, and I was told to walk on my tiptoes, and they'd give me a baby aspirin, and that did absolutely nothing. So I just learned to not tell them. I just don't talk about it.
Do you know about what age they started?
Well, I don't know. I know that I was admitted at 17 months in Denver. We went to visit my grandmother, and she said I wasn't walking right, wanted my mom to take me to her doctor, and he put me in the hospital in basically in the splits. I diagnosed with congenital hip dysplasia, and they acted like it was child abuse or something. They wouldn't let my mother stay in the room with me. She could only visit for a short time every day. They refused to release me until I was under the care of a medical team, which turned out to be Arkansas Children's Hospital in Little Rock, who did a great job. Like I said, I had a wonderful surgeon, but yeah, I was 17 months when all that started.
Very young. Well, can you give us a little rundown on what happened to you through your life? Because we just had this really excellent film done on Complicated. And one of the messages is that children and teenagers and young adults are overlooked with this problem. And then they get to be older adults like you, and then you're diagnosed after you've had all these complications that we could have stopped. Okay.
Would have
So
been nice.
give us a rundown on what's happened to you sort of stepwise at each decade of your life.
Well,
How about your 20s? Tell us what happened in your
my
20s.
20s were good. I had my first hip surgery. I was in 3rd grade. The doctor took bone from my upper right hip or pelvis and made a shelf so that my joint would be stable in my left hip, and that worked really well. I was able to walk after a body cast and crutches and all. After I healed up, I did really well. It would hurt if I walked too much, but I knew just to stop and it would get better. I was doing pretty good. I felt great. I had my first child, and actually it wasn't a complicated pregnancy. Everything seemed fine. I got my degree and I started teaching. It's just normal. I did great until I had my 3rd child. I was 33, and it's like everything hit the fan.
Which thing hit the fan first?
Well, my back. It's like uh, I was in the floor braiding my daughter's hair, and my back hurt, so I laid down to get the pain down, and then I couldn't get up. I've fallen and I can't get up. Only just laid down, and there was no way I could get up. I tried everything. 12 hours later, I finally just had to call the ambulance, and they had to haul me out of there, and I was admitted in traction, and yeah, that was awful. Really, really bad pain. They said, um, that sciatic nerve that went all the way down my leg. That was scary. It was the first time it was just like, this out of the blue. I didn't do anything. I wasn't playing football. I didn't fall. I was just sitting in the floor braiding my daughter's hair, and my back went, nope, no more. Bye bye. Crazy.
So this was when you were 33. So, all right, let's go on to, you're now age 40. What's happened in
Okay.
your 40s?
Well, in my when I was 36, I had a total hip replacement. And it took forever to find a doctor willing to do it because I was so young, but I did find a really good sports doctor. He had his own method. He was amazing. It was a really good hip. For the first time in my life, I could walk without pain. My back was bothering me, but I could walk. It was wonderful. And in my 40s, a doctor told me that it wasn't wearing right and I would need to have a revision. And the way I understood it, they were just going to replace the plastic cup. He said that it wasn't wearing right. I thought, just replace the cup. I'll be out of here. I'll be back to work by the new year. So I made all my lesson plans and had everything ready I thought I was going to be out from Thanksgiving and be back in the new year. But it turns out when he got in there was too much bone loss and tissue loss, and apparently it was just a big mess, and he ended up having to put this giant metal on metal hip in there using donor bone cement screws that in the x-rays look like they go nowhere. I ended up with a lot of metal, and I never could really walk right after that. I can walk but not well, and it hurts.
Okay, so let's move on now to your 50s and 60s, and you were finally diagnosed with EDS. How did that come about?
Well, my dermatologist actually. I had brought it up to PCP. I brought it up to ortho. They all said, "Yeah, sure, you've got symptoms. You know, you're hypermobile, but since EDS has no cure, there's no sense in getting that diagnosis for all that expensive genetic tests." So I just, nobody wanted to listen to me, so I just dropped it. But when I went to my dermatologist, we were talking and I just showed her, a couple of my stupid human trips, just touch my thumb to my wrist and, stretchy skin. And she just went, okay. She referred me to the genetics department at UAMS. And that's where I got my diagnosis.
Are you aware that Eilers and Danlos were dermatologists?
Yes, I thought it was so strange until I found out they were dermatologists. That's why it's called Ehlers-Danlos or Ehlers-Dan. Anyways, I was surprised until I realized how it got its name. Yeah.
Now, tell me what's happened to you since that time. And are you able to function now? Are you work? Are you in bed? What's your situation now?
Well, if I may go back to 2004, when my back had just been bothering me so much. I was in my mid 40s, and it was just hurting so bad. I'm trying to work. It was killing me, and I went to a back surgeon, and all my life everything been fixed by surgery. Like my hip got fixed, get it replaced, get another one, and I thought they could do that with my back. So I go in and I'm asking for surgery. He did an MRI and told me there was nothing he could do, that he could maybe do a fusion, but my body was already he showed me on the MRI that there were little fingers of bone between the vertebrae, that my spine was fusing itself. And he said, your body's doing it by itself. There's no reason for me to go in and operate. There's really nothing I could do. He diagnosed me with degenerative disc disease and said it was just it's progressive and it's just gonna get worse, which was hard to hear. I wasn't ready to hear that, but after I got through crying, he said he was gonna send me to something called pain management. And I didn't know what that was, but I did start. Well, first they started with a shot, uh, a spinal injection, done very carefully as an outpatient in the hospital. You could see the needle on the monitor, nurse, doctor. It was done very professionally, and it didn't seem to hurt me. It didn't hurt like at all having it done. Anyways, it just wasn't effective. It didn't really help. So then they tried medications. I got like uh, one 10 milligram hydrocodone. I got 30 of those for a month, and they, tried me on that. I had taken NSAIDs for decades. They had thrown everything at me in the whole book all my life, but really no opioids except for like right after surgery. I didn't know that that was even a possibility. So yeah, I was kind of shocked, and it worked. Finally, a medicine worked for my pain. I was floored and amazed and all that good stuff. But so I got treatment. It was wonderful. I got my life back. I was able to work without laying behind my desk crying at lunch, and um, it was great. I was able to go out to eat, go to the movies, just clean house, have a life, and that just went on. Then my mom had a stroke, and I moved to Northwest. I was in Little Rock at the time, and then she had a stroke, and I moved up to be closer to her, and that's when the CDC came out, and the doctor that I'd been referred to up here had lowered me, but I was okay with it. It was still okay. But then when they knocked me down to 90, that caused problems. And what you just do, you just try to keep going is all you can do. Um, but thankfully I found you and I started following some of your recommendations. And one that I would have never thought of in a million years was to walk on a trampoline. My granddaughter here has a trampoline in the backyard, and I would have never thought of getting on that. But I got on there and started walking around. And then I even got to where I could bounce gently, not like my feet aren't leaving it. I don't dare do that, but just
Yeah.
bouncing and actually getting some exercise and doing the stretches. And, you know, when I went to the doctor last Friday for my yearly physical, I had actually grown almost an inch. I mean, I haven't really grown, but my spine has decompressed somehow by the exercises. I don't know. I just can't explain it. How did I somehow get taller? Or, I mean, I used to be 5'10", but then I shrunk to 5'8", and now I'm 5'9.5". Go figure.
Yeah, well, makes sense, huh? But your story about the trampoline is one that I've heard many times, and ought to be. And actually, the reason why trampolines work is it increases its major impact is to increase spinal fluid flow and lymph flow, and so it also starts strengthening discs. And that's why you'll straighten up. Your disc got better. And there's something magic about the trampoline when you're or rocking in a chair. Uh, and so I highly recommend it, as you know. I do it myself, and so does Miriam, incidentally. So that's really good. Medication-wise, now, are you still on the hydrocodone, or what are you doing for medications?
Well, they just cut me again. Arkansas, the medical board has decided that. Oh, I guess I'd say they drank the Kool-Aid by the gallon. They've decided they're going to go above and beyond the CDC guidelines. Ignore the 22 update and just go full tilt ahead anti-opioid. And they went after my doctor, and now they say he can't prescribe over 50 mme, and no, now get this, no more than 3 tablets per day or 3 doses per day, and it still has to be under 50 mme. So to me, that makes no sense. I don't even know where that came from. The CDC never said anything about this. Like, what? And the interesting thing is, he had followed all the CDC guidelines. No patients were over 90. Everybody, like, he ticked all the boxes, did everything he was supposed to, and then was shocked to find out he somehow wasn't. But they kind of made up their own little rules to go behind it, where they're putting extra. They said they borrowed it from Iowa. Anyway,
Uh,
yeah, just got cut again. No fun. But they're not going to kill me. I'm not going to let them.
Mark, Scott, we've got a few minutes left. Do you have any comments about her 50 milligrams or any questions you want to ask her?
They're
On
just
at
pulling
45.
Disappointment.
uh, the disappointment. It's amazing because they're just making stuff up. They're pulling stuff out of the air. They have no, in a world of evidence-based medicine, they have no evidence to support dropping down that low.
Yeah.
I can't.
So
figure it out.
what's their motivation to drop it that low? Why are they doing this?
I
I mean,
can't
give,
imagine why.
Fear of badness.
Power, control.
Stop it. So
Well,
so they're afraid that that they might be seen as rural hicks by continuing to give enough medicine to someone who needs it, and that they're not up to date like everybody is everywhere else in the country. So in fact, they're so up to date, they're beyond what everybody else has done.
what they
And
actually said was that Arkansas was the second highest prescriber, and they did not like that we were up there, so they just decided we're going to bring it down. But what they're not thinking is Arkansas is a poor state. A lot of people doing manual labor, and they tend to get injured, and we happen to have more people with pain living here, and they're not. That goes out the door. They don't care
yeah,
about diagnosis, none of that. But that's why.
Well, the problem is somebody's always going to be at the top of the list, no matter how narrow the margin is.
Bingo.
You can be at 45 milligrams and every other state's at 25, and you're still at the top of the list. That doesn't mean anything. Somebody's always going to be top. Somebody's always going to be at the bottom.
Right.
Exactly.
Mhm.
This is
But,
good.
you know, I hate to tell all of you still haven't given me a good reason for this ridiculous decision.
Well,
Okay.
superstition is never a good reason, but that's what it is as far as I'm concerned.
Their superstition of who? You? They're afraid Mark Gibson's going to be on them.
Yeah.
That's a good reason. That's a good reason.
Yeah.
Okay.
They think the DEA is going to run in and arrest everybody.
Yeah. Have you, to close out, have you complained to any of your state representatives, to the Medical Board of Arkansas? Have you personally tried to make your case known to anyone in Arkansas?
The medical board in Arkansas doesn't let you go to the meetings. I can write a letter. They won't read it out loud. They'll take it for information. They have like a big steel door around themselves, and they don't let anybody in.
Do you have in Arkansas? Do you have elected state representatives?
Yes. One of
Well,
them, I just got a form letter. They always ensure me that they're working on the war on opioids, and it's like they ignore everything I say and just hammer in how strong they are. They're working on that war on opioids and the opioid epidemic, and that they. I don't know. I don't know why they send me those letters that have nothing to do with what I said. I've written everybody from the president to my elected officials, but there's a new one that's kind of close by me. I'm going to start seeing if I can make progress with one, just one.
I like that. Well, Anita, thank you for bringing this
Go in
issue
person
up.
if you can.
There you go.
And I can because they're close enough to me. Yeah.
I do have one question, if I may, Danita, for all the other Danitas out there that may watch this show and hear your story and think to themselves, oh my goodness, this is me. Is there something that you may be able to think of that if you could tell the person one thing, what would that thing be? Is there anything that you could think of that might help that person? Would it be to keep pushing for answers? What would that thing be?
It would be creative. Like we're on our own, and I've done the weirdest things that somehow work sometimes. Like, okay, one of my joints is unstable, it's hurting. I put a brace on it. You buy it on Amazon. We're kind of on our own, and I had, I don't know what you call it. We're a little like nerve pain all down my arm, down to my finger. So I had a brace on it, and then it just hit me. Why don't I, Doctor Tennant had said something about hormones and how our body's receptors need them to heal. So I took some of my bioidentical hormone cream that's prescribed to me because I'm 66. So yeah, I need some extra hormones. Thank God I get that. And I decided to rub some of that cream on my thumb and my wrist there. And it worked. It helped. The pain's gone. It's still numb and tingly, but that pain that was so awful healed. And I don't have any other thing to
Wow,
say other than that hormone cream actually helped.
that's
Does,
wonderful.
does. Yeah. Well, it's been a great session. Thank you so much, Anita. You've given us a great deal of food for thought. Mark, keep us abreast on this trial. That would certainly be nice to see things go as you predict. Again, Jamie, Miriam is right here, and I think I can speak for her in this case. Thanks. You're very kind. And we'll see you next week. And incidentally, if anybody's got any ideas out there how you can live with 50 milligrams, substitute, supplement, anything, we'll take your
Please.
ideas. Okay. All right. And Scott, again,
Yes,
your
sir.
words of wisdom are always good. And
Well, thank you.
you will have good ideas, and we'll, again, I'll ask you also as our in-resident PharmD now, how can she take 50 milligrams and extend them or potentiate them? And that will be a good subject for next week. Okay, we got a lot
I
of
will
people
work on
at
that.
her boats. They've been tapered down, they've been mistreated for reasons that no one has given me a good explanation for yet. But nevertheless, it's a fact. And so what do we do to help people who are down to 50 and need to be on 80 or 100, but they're not? What do we do? Go to work, Scott. We'll count on you to have the answers next week, okay?
Well, there's
All
a
right,
lot
I'll
of
give it a
there's a
try.
lot of clergy in Arkansas. Let's ask them too. Lots of
There you go.
clergy in Arkansas. Let's ask them.
There you go. Yeah. Well, you know my opinion. I've not been happy with the clergy about all of this. Okay.
Yeah.
Anyway,
There's no shortage of prayer. I can pull over to the side of the road and they got little prayer tents. Do you want a prayer? Pull over. I can just go through the drive-through prayer. And I mean, that's great. I would like my medicine though, but
yeah.
I'll take
How
a
about
prayer.
how about a little medicine for a prayer? How does that sound?
Well, God made the poppy for some reason.
Yes,
you
he
go.
did.
And you know, we can grow them. That's not illegal to grow them.
Yeah.
There you
Well,
go.
I'll close with this statement. Christ tried to drive out those demons and relieve suffering. Arkansas should get that message. Okay.
Yeah.
Good night.
Thank you.
Amen.
Good night,
Amen.
everybody.
Amen.
Good night.
Good
Thank you,
night.
everyone.
Thank you.
Good night, everybody.
Love you
Pray for
guys.
Dr. Anand.
Yes,
Yes.
definitely.
So glad seeing you, Jamie. God bless you.
I'm so glad
Bless
you're
you
better,
too.
Jamie.
Yeah. Keep
God bless
keep
us,
getting better.
everyone.
We're praying.
Thank you so much. And we'll see you next week. We have a great show already ahead of us for next week. So please be prepared. See you then. You're not alone. Good night.
Thank you.